Greetings everyone and welcome to this YouTube live session. I am Dr. Noor, and today I'll be representing a detailed case study on Becker's muscular dystrophy, also known as BMD. I want to thank everyone joining from different places, especially all the medical students, physiotherapists, and clinicians who continue to show interest in these educational sessions. This lab discussion aims to highlight the clinical features, diagnostic process, and evidence based rehabilitation management for this condition. Let's start with a brief overview. Becker's muscular dystrophy is a genetic neuromuscular disorder caused by mutations in the dystrophin gene that leads to the production of an abnormal or partially functional dystrophin protein. Unlike Duchenne muscular dystrophy, BMD tends to have a later onset and slower progression, allowing many patients to remain ambulatory well into adulthood. Our case study today focuses on a 41 Our case study today focuses on a 41-year-old male diagnosed with muscular dystrophy at the age of 26 who presented with shoulder blade pain radiating to the arm and recurrent sacroiliac joint. Let's go through the case systematically. Chief complaint was shoulder blade pain radiating to the arm and recurrent sacroiliac pain for the past few weeks. In the past medical history, diagnosed case of muscular dystrophy underwent stem cell therapy and remains compliant with regular physiotherapy and exercises. No reported cardiac or respiratory complications. In family history, positive as his maternal grandfather had muscular dystrophy. While assessing the pain, we observed the pain in shoulder blade and SI joint, mainly right-sided. Onset was 2 months ago. The nature of pain was described as a dull, intermittent, and radiating pain to the arm. Relieving factors were relief from exercises and foot pack. Exacerbating factors were weight bearing on arm and prolonged sitting. And the severity was, according to patient, the pain was 6 by 10 at worst. On objective examination, we observed waddling gait and no visible swelling or bruising. On palpation, we noticed trigger points on infraspinatus, supraspinatus, and trapezius, also in piriformis and quadratus lumborum muscles. Evident muscle wasting in proximal muscle groups, particularly around the shoulder girdle and pelvic region. Weakness in both shoulder and hip muscles group. In MMT, we tested shoulder internal and external rotators weakness, scapular retractors weakness, shoulder abductor weakness, hip internal and external rotators weakness, hip extensors weakness, and abdominals weakness. In neurological examination, reflexes and dermatomes were intact. Special tests revealed positive Faber, distraction, and sacral thrust test confirming SI joint dysfunction, while negative nerve tension and cervical test ruling out radiculopathy and nerve entrapment. Let's move on to the differential diagnosis. First one is myofascial pain syndrome. Why we consider this diagnosis? Because a referred pain patterns correlating with the shoulder blade and arm pain and trigger points on palpation. No reason was to eliminate this condition. Next one is nerve entrapment syndromes. The reasons were radiating pain in the arm due to entrapment or compression at any point in the nerve's course. The reason was to eliminate this was because nerve tension tests were negative. In cervical radiculopathy diagnosis, the reason was to consider this radiating arm pain with shoulder blade discomfort can be caused by nerve root compression in the cervical spine. Why we didn't consider this diagnosis, which was cervical radiculopathy, because there was no neurological deficits. In SIJ dysfunction diagnosis, the reason was to consider this patient reports unilateral pain localized over posterior superior iliac spine region. SI provocation tests were positive, palpation tenderness over SI joint region. There was no reason to eliminate this diagnosis. In hip joint pathology, patient presented with pain around the posterior pelvis and buttock, which can sometimes be referred from the hip joint due to shared segmental innervation. The reason was to eliminate this diagnosis. Faber and Feder test were negative. No groin or anterior thigh pain was observed. SIJ stress tests were positive. In lumbar radiculopathy, the reason was to consider this. Although the patient's pain was localized to the lower back and buttock region, lumbar radiculopathy was considered because no nerve root irritation, especially L5 to S1, can sometimes begin as localized pain before progressing to radiation. The reason was to eliminate this diagnosis. SLR and slump tests were negative. No reproduction of radiating pain below the knee. So, based on findings, our differential diagnosis included myofascial pain syndrome, SIJ dysfunction, joint dysfunction, and lumbar radicular. Oh, sorry, only myofascial pain syndrome and SI joint dysfunction. So, let's move on to the treatment plan. How can we manage the myofascial pain syndrome? In physical modalities, we can use therapeutic ultrasound and hot pack to reduce muscle spasm and pain. Manual therapy and trigger point deactivation. It includes manual compression, deep stroking, and strumming to deactivate myofascial triggered points. Gentle stretching exercises, prone assisted YTW exercises, scapular push-ups on wall, scapular retraction without resistance, supported external rotation with towel roll with slide resistance. Now, what are YTW exercises? These are shoulder and upper back strengthening exercises that target the scapular stabilizers, which are the muscles around your shoulder blades. They are called YTW because your arms form the shapes of the letters Y, T, and W when viewed from the front or above. They are specially used for postural correction. Shoulder rehabilitation, like in rotator cuff injuries, muscle dystrophy, or scapular dyskinesis, reducing neck and upper back pain, improving scapular control and stability. In this, muscle targeted are lower and middle trapezius, rhomboids, serratus anterior, posterior deltoid, rotator cuff stabilizers. How can we perform these exercises? To perform Y exercises, lie face down on a mat or stability ball. Extend your arms overhead at a 45-degree angle, forming the letter Y. Keep thumbs pointing up. Lift your arms off the floor by squeezing your shoulder blades down and together. Hold for 2 to 3 seconds, then lower. Focus. This exercise focus on lower trapezius activation. T exercises. From the same position, extend your arms straight out to the sides at shoulder level, forming a T. Palms face down or thumbs up. Lift arms and squeeze shoulder blades together. Hold for 2 to 3 seconds, then release. This exercise focus on middle trapezius and rhomboids. Next one is W exercise. Bend your elbows at 90 degrees and pull them close to your sides, making a W shape with your arm. Lift elbows slightly and squeeze shoulder blades down and back. Hold for 2 to 3 seconds. This exercise focuses on scapular retraction and external rotation. 2 to 3 sets of 10 to 15 seconds, 10 to 15 repetitions for each shape, performed slowly and controlled 3 to 4 times per week. Can be done prone or standing against the wall or using resistance bands. While doing these exercises or performing these exercises, avoid shrugging your shoulders, keep your neck relaxed, focus on the movement coming from your scapula, not your arms. Don't use weights unless strength improves, start body weight only. How can we manage the SI joint dysfunction? Physical modalities include therapeutic ultrasound, hot packs to reduce muscle spasm and pain. Manual therapy includes SI joint mobilization. Gentle stretching, it includes piriformis stretch. Exercises include pelvic, rolling gluteal squeeze bridging, modified pelvic circles. Short-term goals. Short-term goals include reducing pain, deactivating trigger points, restoring pain and range of motion. Midterm goals are to improve mobility, increase strength. Long-term goals include return to pain-free daily and functional activities, prevent recurrence through self-management. Prognosis. Favorable early physiotherapy and good compliance improve functional outcomes. Expected outcome is pain reduction, better posture, and improved daily activity tolerance within 6 to 12 weeks. Risk of recurrence is possible with overuse, poor posture, or disease progression. Patient established Becker's muscular dystrophy at the age of 26 and confirmed through elevated creatine kinase levels and EMG findings consistent with a dystrophic pattern. He is currently undergoing stem cell therapy, which has yielded remarkable clinical improvements as a part of his ongoing multidisciplinary rehabilitation program. Assessment tools and prognosis. Clinical assessment tools included for the Becker's muscular dystrophy, 6-minute walk test, timed up and go test, manual muscle testing, and North Star ambulatory assessment. Diagnostic evaluations such as EMG, genetic testing, MRI, and CK levels helped confirm the dystrophic pattern. The prognosis is favorable with early physiotherapy, consistent rehabilitation, and patient adherence. Orthopedic or surgical management, pharmacological management, stem cell therapy, and gene therapy. What is stem cell therapy? Patient underwent successful stem cell therapy in Thailand 2 months ago, resulting in significant improvement in muscle strength and functional capacity, comparable to his condition at the time of diagnosis. Clinical impact enhanced muscles endurance and slowed disease progression, supporting better physiotherapy outcomes. Involves using regenerative cells that can repair or replace damaged muscle tissue. It aims to restore dystrophin expression, reduce inflammation, and slow muscle degeneration. Commonly uses mesenchymal myoblasts. Global results, safe in most trials, show functional improvement and slower disease progression through outcome vary. Still considered experimental but offers promising adjunctive results when combined with physiotherapy. In this case, therapy in Thailand led to marked improvement in muscle strength and function comparable to the pre-diagnosed level. To conclude, this case highlights how a multidisciplinary approach involving physiotherapy, regenerative therapy, and patient education can significantly enhance outcomes in Becker's muscular dystrophy. The key takeaway are early intervention and consistency in therapy are crucial. Myofascial pain and SI joint dysfunction can coexist with neuromuscular disorders. Rehabilitation must be individualized, progressive, and patient centered. Thank you all for joining this live session. If you found it informative, please like, share, and subscribe to the channel for more case-based medical discussions. Feel free to drop your questions in the live chat or comments. I'll be happy to answer them. This is Noor Mustafa signing off. Stay safe, keep learning, and keep moving forward in your professional journey.